Okay. Hello and welcome to this afternoon's meeting of the Integrated Care Partnership. Thank you everyone for coming. Do we have any apologies?
Hi, yes, we have apologies from Stephen Bateman, Avia Batia, Carol Camis, Chris Clayton, Mary Dooley, Karen Hanson, Kim Harper, Helen Henderson, William Legg, Stephen Posey, Drew Smith, Andy Smith, Hal Spencer, Jeff Sweeney and James Moore.
Thank you, Lindsay. We don't have any late items. Do we have any declarations of interest? No. Thank you. And is everybody happy to confirm the minutes of the ICP meeting on the 13th of December 23? That's a thumbs up from Richard Wright. So do I take that as a general assent in the room? Thank you very much. Okay, well, our first item today is an update from the Integrated Care Board, which normally Chris Clayton speaks to. So who's going to speak today, please? Thanks, Michelle. Thanks. Are you able to put your mic on?
There we go. Apologies. So I mean, obviously, I'm sure people have read the paper, but if I can just bring a couple of highlights. So we'd like to, just to note, Dr. Cathy McLean joining us as our new chair on the 1st of May. So we all will look forward to welcoming Cathy. And I'd just like to, at this meeting, just thank Richard Wright, who's been acting as our interim chair and continues for a little bit longer until Cathy joins us in May. But thank you to Richard for his work in that role. The second thing I'd just like to point out is the NHS planning. Excuse me. So we are full in the throes of our NHS planning, and as you know, we had our first version of the joint forward plan, which is our plan for the NHS, which we landed on the 30th of June last year. We are currently in the process of refreshing that plan along with our operational plan for 24-25. There's a significant amount of work ongoing at the moment and quite a lot to work out in terms of balancing both the immediate and short-term priorities along with the longer-term priorities, and particularly aligning to the Integrated Care Partnership strategies and the Health and Wellbeing Board priorities. And then I'd just like to point out our Integrated Care Board restructure. So our staff have been undergoing a restructure, and we finalise that tomorrow. And we will be soon to, after tomorrow, putting the implementation plan in place. And my last point, just to highlight really, is the operational service pressures that the NHS has been under really since December. So particularly post-Christmas and January, we've seen significant pressure alongside some industrial action that's had some further impact around that. I'd just like to note here our thanks to the frontline staff. They have been doing a great job in terms of caring for the population of Derby and Derbyshire in quite challenged circumstances. And just to highlight a couple of positives really from the winter planning and the operational planning that has been going on around our discharges. We've seen significant improvement around our discharge profile, particularly in the more difficult discharges. And also in terms of our ambulance delays, we've seen quite a pressure in this area, and actually both the management and the frontline staff have really done some sterling work in terms of improving and reducing the ambulance delays, which is making a big difference in terms of being able to get care and access to patients in the community. And just finally, there has been quite some increase in COVID and flu presentations that we've been dealing with in those pressures. But I'll leave it there, and I'm happy to take any questions.
Thank you, Michelle. I've got a few comments myself, but I'll bring others in for questions first of all. But before I do, can I congratulate Cathy McLean on her appointment as the chair of the Derby and Derbyshire ICP, and I know that Richard Wright will be continuing in his stalwart role as the vice chair, so we won't be losing Richard, thankfully. And I'd like to congratulate Mahmoud Nawaz as becoming the chair of the Derby at Chesterfield Royal Hospital Trust, and also mention Keely Sheldon, who's mentioned in the report, congratulate her on becoming the development of quality and safety at EMAS. Does anyone have any comments they'd like to make on this report update from the ICB? No? Well, will the room, I hope you'll indulge me if I make a few comments, please. Goes back to those days of me being the scrutiny chair. So I'm pleased that the hospital discharge scenario, the ambulance handover scenario is working better, because a couple of years ago that was really, really difficult. I mean, these are areas that really, really do distress people in Derby. I speak mainly for Derby on this. I can't speak for the other hospitals, I don't know very well. So I'm pleased that has improved. I think there's a point about discharge, but I think I might bring that up in your report, Tracy, because it comes up again there. So for the moment, it is really pleasing to see that there has been an improvement in that. I think it's very important, as everyone knows, for the whole system. I'd just like to have a comment on the GP practice scenario, which again I know is really, really important to people of Derby and Derbyshire. I think it's positive that there are more appointments because of the introduction of more healthcare professionals into primary care. However, I don't think that should detract from the need to increase the number of GP appointments specifically, and I know that is actually reliant on employing more GPs and having those GPs to be able to select from and employ. So I don't know, I know that you're not the author of this report, Michelle, but I do think that's extremely important, because I do think that for a lot of people, whilst seeing a nurse may be appropriate, sometimes it's like self-diagnosis, and they're seeing the nurse, and then actually it turns out they could have done with a bit more of an analytical, GP approach to looking at what their problem actually is at the outset. So I think there's a bit of kind of like better if the GPs are acting more of a triage person than, say, the receptionist. This is something I've talked to her about a lot before, but I just wondered if you'd got any comments on that could reassure people that the focus is not on, you're not losing focus on the need for more GPs.
I'll make a comment to begin with, and then actually my colleague Duncan might make a comment as a GP in the room. Understand the point you're making and hear that, Councillor Martin. I think there is a whole access recovery plan that's a national plan around primary care and actually improving access to both general practitioners and other healthcare professionals in that primary care setting. And so there's a number of work streams underway, and so there's a significant amount of work in this area to do exactly that, to be able to improve further what we're doing in this space. But I'll hand to Duncan, who might just want to give a more detailed comment from the front line.
Thank you. I think we would all recognise the challenge with access to general practitioners in particular, and the important role that they play within our health economy. I do think it's important that we don't put down the other important members of our multidisciplinary team, our clinical pharmacists, our nursing teams, who have expanded their capability through extended and quite advanced professional training to allow them to take on diagnostic roles. I was pleased in the sort of early winter ICB board that they adopted the primary care clinical model, which for Derby and Derbyshire, which seeks to try and prioritise access to general practitioners where it makes the most difference to their outcome. So where people receive the most benefit from the delivery of continuity of care with individual general practitioners, we can focus on providing that in a more enhanced way. The counterpoint to that is that means that there will be groups of people where the need to see a general practitioner is lower, who are less likely to see them. On the overall point of access to general practitioners, we've seen an overall reduction over a number of years in the total numbers available of general practitioners, and that's a challenge that most of us are trying to tackle, and is something that we're working very hard in Derby and Derbyshire to work against with a variety of retention schemes, and things look reasonably optimistic at the moment, but it's certainly at the early stages of improving that.
Okay, thank you. So are you saying there that there's still a focus on the recruitment, retention and expansion of the number of GPs in primary care?
Yes, there is. Absolutely.
Thank you. Councillor Hart.
Yeah, just on that, we had a presentation from Helen at Healthwatch. I don't think she's here today, sent apologies, isn't she? And really, I think that was one of the items that came up. It was the frustration of trying to get an appointment. And funnily enough, I'd sort of experienced it myself, because I went to the local doctors and no, they hadn't got an appointment. And pointed me in the 111. I went on 111, but you try and go online to help them, unfortunately, at the end of answering the questions, it said, go back to your GP. So it was a little bit like pillar and post. So I think that is the frustration. And of course, the 8 o'clock in the morning syndrome, where everybody's trying to get that appointment. But I think some doctors now are trying to do a different system, you know, because it is a bit chaotic. You know, you start at I've not had to do it, but only from the feedback, as I say, from Healthwatch. And I think that was just more or less frustration. They understand that doctors are under pressure, but it is, you know, you feel as though you're being pushed from pillar to post sometimes. So it's just an observation, yeah.
Thank you, Carol. I totally agree, and that's very much what most people feel. And this has been reported, obviously, to the ICB and to Clive Newman, the long-suffering, as I always call him, Clive Newman, several times. It's just to keep on that focus, really. That's the feedback from us who represent people, is that people do want to see their GP, and we understand the value of the other professionals, and we're not doubting that. It's just that there's increasing element of self-diagnosis, which may not be appropriate. And secondly, that all the things that are happening are very valuable, and we recognise that, and we recognise everybody's doing their best. It's just to be absolutely sure, as you've just confirmed, that, you know, that doesn't replace the more fundamental problem, is that we still need more GPs. So as long as the focus is retained on that, I think we can draw some reassurance from what is a service that is not satisfying the public at the moment, unfortunately.
I do think within this environment, it's important that we understand the problems so that we can communicate appropriately to those that we represent or that we advocate on behalf of. It is likely to be you're less likely to be able to see your own GP in coming years. And there's multiple reasons for that. But if the numbers are declining, the complexity of individuals who benefit from access to a GP is increasing, and therefore requires a longer appointment time. And those GPs are having to provide an increasingly supervisory role within their work to a larger multidisciplinary team. The total number of appointment count may go down, and that would be us increasing productivity, improving quality. So there's a really important nuance to this, whereby there's a way everyone could see a GP, but it wouldn't necessarily be of a high quality interaction with the right people. What we've got to retain focus on is increasing numbers and increasing it overall, but really focusing on improving productivity and quality at the same time.
I hear what you're saying, and I'm going to draw this to a close because I'm the only one. You know, this discussion comes on the back of many discussions that I've had and have taken place in this chamber with particularly Clive over these issues. So I appreciate what they're trying to do. I think the message, though, and I understand that the services have to evolve and they will change over time. And I know that there's no quick fix to this problem, but I feel it's incumbent upon me as somebody who's elected to represent people just to say, and I believe that Councillor Hart was largely concurring in her account of that the actual ability to see a GP for many people is very important, and that's what they want. And they won't always need to continue seeing that GP. They may need to see a physio, a pharmacist, you name it. But that is still a desirable focus in the service for the people, which the NHS is there to actually serve, and that is what people want. So as long as there is we're not losing sight of that desire and that aim for more GPs or more GP appointments, I think, you know, that I'm happy with that. Okay, but thank you for that. I'm going to call that to a close, Richard, unless you've got something compelling to add.
I think I just wanted to add that one of the things within the ICB we're increasingly looking at, you probably understand that the ICB became responsible for other primary care services at the beginning of this year, so pharmacists, everything else. And we're increasingly looking at access to localised care in the round. So I think that picks up on what you're saying there, but also looking on how we communicate that. And the 111 service, for instance, will change. It's a new contract next year, so some of that is provisioned into that. So I think Duncan's right in saying we can't always promise that the access will be as it was 10 years ago, I'm afraid, and services do. But actually, we've invested a lot of money in those additional services alongside GPs, which means that people can access the service that's right for them at the time that they need it. And we're having to get a lot more clever at that at the moment. So I think looking forward, I would hope that 5 years from now, if we look at, we had a meeting this morning, we talked about a 10-year vision, just for instance. Robin put it up there in front of us, was very much about, where do we want to be 5 years from now? And it will be much more around this holistic view of primary care and how people access the right primary care with the minimum of fuss in the minimum timescale. I would just point that out, really, I think, going forward.
Okay, thank you, Richard. Well, we'll keep discussing it, I think. We'll keep the conversation going because it is an area that's so important to people. And on the 111, I think it's good to see that the DHU Healthcare's Chesterfield-based urgent care service, they've had outstanding by the Care Quality Commission, so that's good to see. And the final point for me is that, but I think we can again pick this up in your report, Tracy, about the increasing numbers of people who are being diagnosed with dementia. And I understand from the people who briefed me on dementia, some of the charities, that this is very important to increase diagnosis, but I think we probably need to think about how we deal with that as a the follow-on from that. So maybe we could talk about a little bit about that, pick that up under your report, Tracy. Come back to that perhaps, because it's just an item noted here. But I know that dementia is, more and more of us. I'm told that by, 1 in 3 of us will have dementia. So it's, and it's going to become more and more of an issue. So it's obviously something we need to study. Right, okay. If there aren't any further comments on that, I'd like to thank Michelle for delivering the report, and Richard for intervening there. And now we'll move on to probably what is the main item for today, is on the integrated care strategy theme focus, age well, die well, age well even and die well, and that's Tracy Allen and Kate Brown together. Thank you.
Thanks, Councillor Martin. So you'll have seen the paper that we've pulled together to attempting to summarise the huge amount of work that partners across the Integrated Care Partnership are doing around this age and die well, which is the third strand of our integrated care strategy and a really huge key area of focus for us. So just click on one slide, thanks. I won't read this out, but remind you all what we signed up to. And this is about a focus on supporting all of us as we age to live healthy, independent lives, to work with us on what matters to us, the strengths that we and our families and communities have got, to stay in the place that we call home for as long as possible. to be supported to manage escalations and to get back the independence that we can when we've managed those escalations. So the paper's really comprehensive. I'm going to hand over in a moment to Kate, who will take us through the presentation. But if we just look at the next slide, and it's covered in the paper, and in fact, Councillor Martin, you've already referenced it tangentially around dementia. You know, we all know that the population of Derby and Derbyshire is growing, and that the growth in the older cohorts of our population is outstripping the average growth. Even more significantly, and Robin and Ellie were doing some work with the ICP board this morning around health inequalities, is the fact that actually, whilst we're living longer, we are increasingly living more years in poor health as we age. And so you have to overlay the impact of that onto these kind of gross figures in terms of ageing. So we've got a combined priority to support people to stay as well as they can, and to be able to support them to maintain and get back their independence when they are suffering from health issues in their older age. So I'm going to hand over to Kate, we're going to summarise the paper and then come back for discussion, because it is a very broad and complex work programme, multifaceted, multi-stranded. I think the thing I'd want to draw out at the beginning is that this is work that all of our organisations are engaged in through the Derby City Place, the local place alliances in Derbyshire County, and it's coordinated by the Integrated Place Executive. So we've got general practices, the PCNs, the NHS organisations, the local authorities and the voluntary sector. And we're presenting work that is being driven bottom up by our colleagues right across all those organisations. Thank you.
Thank you. Can we have the next slide, Lindsay? Thank you. So as Tracy mentioned there, a lot of this work is coordinated and supported through the Integrated Place Executive, but is happening in all organisations and across the whole system. But the Integrated Place Executive last year commissioned some work to understand what the improvement opportunities around the range of things that are occurring as people move through our system. So that process, we brought an external company who did some really detailed data analytics from across the whole system. They had over 180 staff who participated in workshops, and they reviewed individually 200 cases of people aged over 65 where there was potential opportunity for improvement, and the conclusions are shown on there. And they were tackled in if everything existed, if everything in the community was in place, if every opportunity, every interaction had been responded to, what might have been possible, what's the ideal, what we should be aiming for. And that the view of the detailed work was often at the point those decisions were made, so the decision to put somebody in an ambulance, the decision to admit at the front door, the pathway of care somebody leaves hospital on, they were all determined to be the right thing at that point with the options available. But that if there had been opportunities earlier, other alternative sources of care and support, these are the sorts of percentages of improvement that could have been experienced. And clearly the experience for the individuals who are then not getting that optimum care, we would all recognise amongst our families and friends and the cases and experiences that we see. It's important though to say that the individual care, whenever we analyse individual organisations and pathways of care, is often really fantastic. It's the connections between them, the way we work together that's suboptimal, which is why this is such a key strand of the integrated care strategy and how we can better, as partnerships, work together. We've also done work asking individuals about how they experience care delivered through different organisations, and again, it'll be no surprise to people here that they can say they can sometimes get conflicting advice or information isn't consistent, that transfers of care and expectations can lead to gaps and delays, that some of their preferences and care plans don't move with them as they move around the system, and there can be missing opportunities to intervene because one practitioner might not understand the full support range and opportunities for other individuals. So we're trying to make sure that the work we do in this strategy, in this strand of the strategy, is driven by data, but also driven by those insights And in addition to the work we've done directly, the VCSE Alliance recently really helpfully organised an event where they brought together organisations who work with older people, and that's given us some really valuable insights. And they fed back that they hear that provision can feel siloed in the ways just described, that preferences aren't always listened to, and it might mean people sometimes choose not to access services because they feel they might be stigmatised or they might be out of control. So there's things that are really hard to hear, but really wanted to make sure we're driving this programme of work and how we approach this, really understanding the experience of the individuals within the service that we all provide. Can move on to the next slide. It's really, really complex. That's why, as Tracy described, this is not a sort of programme of work. This is not individual, a single strand of work. This is about trying to understand how we can bring together all the range and complexity displayed there, all those individuals providing all that service, all of which we'll be trying to improve, a majority of the work, a significant amount, supporting older people and aiming to deliver care in line with that overall aim, but not always organised or coordinated or supported to operate in ways that are optimal. And so we need to think about how we can the aim in terms of an integrated care approach to this is to how we can improve it by working together differently. So if we have the next slide. So how do you work with all of that? How do we make sure that we are then bringing that together, working together and thinking differently? One of the conclusions is you certainly can't do that singularly, separately. You can't manage it from a central directive that then tries to work through individual organisations. It's around, and also there's recognition of the expertise of those frontline practitioners, those people who work through the voluntary sector in the communities, and how we enable them to work, because they often understand what needs to change, how they could work differently, and therefore the focus is on making sure there's shared ambition, but building the capacity and the cultures of working in that way, and really ensuring we can work together effectively across all of the sectors, statutory, non-statutory, primary, secondary, community, and at all levels in terms of how we set direction here, how we translate that into plans, and then how we enable that operational delivery at a local level, really driven by the communities, the general practices, the community teams in each area to drive that improvement. So if we move on, thank you. So that approach, as we've said, is about looking where does bringing a team of people together bring the most benefit. And we've started with particular strands of work, the newer work, where we've had some opportunity for investment and to prioritise additional capacity in supporting people in their own home and those living with frailty. Building on national initiatives around ageing well of a couple of years ago that provided some additional resource. That's been a strand of the team up work that people will have heard of, where we have put in extra capacity, but that is all in the context of that wider partnership working across strands of work, which is why this is a very broad programme of things, and some of the aim is bringing together those separate programmes of work in addition to putting targeted additional capacity in. So we've tried to use the infrastructure that we have in terms of place structures, both city, county and local places, and really connecting into those primary care networks that are strengthening and building in terms of how we can coordinate care around people. So the additional new services have focused on those areas. We recognise, though, that by doing some of those pieces of work, there's often anxiety about those organisations who serve across the patch, that there might not be consistency, and it can then be difficult, particularly organisations like ambulance services 111 and the hospitals as they're discharging people, to understand what's available in each area. So we're trying to get that balance of where there needs to be consistency, and certainly consistency in terms of the offer for individuals, and so the population understand what that might be there for them, but then doing that through a consensus about what's important, and then allowing local flexibility where it's possible in terms of how it's delivered, so some consistency of the framework and what's available for people at certain times, whether that's as their health is deteriorating in the community or as they're being discharged from hospital, etc., but to allow that local flavour, building on the range of different services already in existence and the opportunities and priorities in different areas. To do that, therefore, a lot of the focus of the work is to create the conditions by which those teams, those organisations can work together. And I think one of the things that came through very strongly when we were doing the strategy work was around the need to focus attention onto those enablers in terms of the cultures and ways of working. Sometimes organisations, there's different appetites around risk, there's different protocols that can drive individuals trying to work with a person to be coming to different conclusions. So how do we understand where they are and work through those? What are some of those infrastructure elements that enable us to work differently? And I know on the agenda today we've got around a data sharing. There's all sorts of infrastructure issues that we're continually identifying and trying to work through. The skills of the individuals and how we say things like risk appetite, things like working either as generalists but then accessing specialists for support, working differently in that sort of way, and really building in as well a learning approach. This isn't here's a fixed model and we're now going to just roll it out everywhere. What's being rolled out is an approach that says here's a set of challenges, some opportunities, how might we develop a response to that and learn and share. So lots of opportunities for those professionals and cohorts of people trying to make changes to come together and to say what worked for them, and for us to then to be shaping pieces of work rather than have a fixed model that then we a number of years down the line we find out is no longer fixed. On meeting the need. And then a broader aim about some of the programmes of work. You mentioned discharge, we'll come on to that in a moment, about the strands of work that are happening in our system and how we, without trying to overmanage all of them, can make sure there's cohesion between them and connectivity, because lots of the individuals involved in those pieces of work are the same individuals, and the capacity for change improvement can be really challenging, and so we need to make sure things are coordinated. And it's really live at the moment across our whole system about understanding the key pieces of work that are happening and how they connect together effectively. Thanks. In terms of then what have we actually done? So that's described as sort of an approach and a principle, but there's lots and lots of things happening now. And as Tracy said at the start, this really does reflect the work of all of the organisations. The teams mentioned there in terms of local led teams, the predominantly primary care network led teams, integrating a new approach, delivering a new approach to how we do home visiting that tries to make sure the support available quicker and for people to keep them at home rather than if the only option is to transfer them to hospital, and then the ongoing series of events as mentioned at the beginning. We're making sure that we've got our urgent community response services delivered through the community health services who've managing consistently to hit the national targets for a response for those people who need it within 2 hours. We're building falls recovery services across the patch. There were always some services in place, but it wasn't consistent, trying to up that offer. And we now, as of now, have got a consistent service available for people who fall in the community, don't have an injury, but might need some support to get up and for their family, and to try and link that then into the preventative work we can do with those individuals. Lots of evidence that if you have a fall, your risk of having an injurious fall is really high. How are we connecting those services up? Then we have trying to as well make sure that it is easy to get the right care. We're thinking about care homes as well. Another strand of work is there's lots of people, their home, their normal place of life is a care home. How are we working more effectively with those homes, supporting them, offering things like training about identifying where there's deterioration, how they can communicate effectively with the professionals they're working with, where they might then manage falls in different ways. So building that connections on, and again, very much partnership working in terms of the links already with care homes that social care have, and how we're working across the whole system to understand opportunities to support that sector in a different way. We're also thinking the discharge. I think this is a topic in and of itself, and probably this group might want to have a different focus at a different time. But as was referenced earlier, we have spent a lot of time trying to understand collectively where the priorities are, agreeing that the focus needs to be on home care to start with, supporting people to get home fully re-abled and able to remain independent. That then there's challenges then in terms of the need for the community bedded care that supports that when we're discharging people into different facilities. And we know that there's the next strands of work, which will come on to the end, about where we need to look next is definitely into that provision in our system. But we've really seen the difference, and as challenging as this last winter was, I think all partners would recognise that it was better because of the integrated work, that real system focus. The system has put capacity in, not significant capacity to do that improvement work, but it's really made a difference to bring people together, and individual organisations also taking responsibility within their walls, so the acutes really working hard on their own opportunities to improve. But as I mentioned earlier, some of this is about that culture and different approaches. So one of the things we have worked on and continue to work on is moving to more of a strength-based approach, very familiar in social care, about focusing on the individual, what's around them, what can support them, what their community can offer, as contrasted with often quite a risk-averse medical approach in terms of discharge, and really wanting to make sure absolutely everything's lined up and somebody's got a full everything before they go home. And so having those conversations, working through with different professionals about what that means and how we work and think differently about how we work with older people and what's important to them, are some really challenging conversations, but really seeing the benefit of that and people really embracing those different sorts of approaches. Mentioned there about trying to ensure that where we're building up community services, we can then get people into them. So if people will access services in whatever way they feel they need to, whether they'll ring 111 999, turn up at their GP, turn up at the doors of A&E, how do we make sure we can get them into the community services that we're building, which is where we'd want people to, in the first instance, have their care managed, with then obviously being alert to the need to escalate care and input as needs determine. The focus of our work predominantly has been, and pulling this together, has been on the age well element of the age and die well, but we also wanted to acknowledge the work that's ongoing in terms of an end-of-life and palliative care programme of work, looking at how we get greater consistency across our system, how we make sure we are building approaches that support improvements, and the hospice sector is really key in terms of our model of end-of-life care. So that's another programme of work that's underway that's connecting through the way we are bringing programmes together under the place structures, and end-of-life really, really key focus on that personalised care and system symptom management, and looking at workforce and sustainability of that are the sort of key priorities within that end-of-life programme of work. Mentioned a few times about infrastructure, having those core building blocks, paying attention to not new services, and but more about how we're building on what we've got and connecting things. And one of the key elements of that, the community health services and council integration, is another core element of that, where we're seeing formally in the city, Derbyshire Community Health Services and the City Council bringing the reablement teams together, and less formally, but just as much progress in terms of the county about working differently, making sure we're thinking on the same footprints in the county, and how we can organise teams to work better together. There's greater opportunities that are being examined about all of the ways that teams work together. So we've ultimately, when we're trying to look at the impact of this work, and as you'll imagine, each of the strands of these pieces of work have got the data that sits behind it, the numbers of people, the increased activity that's happening in the community, the way we've been seeing the improved discharge improvement, and we are, despite it being incredibly challenged, I think we're 11th in terms of the number of days delayed across the 42 systems. And one of the broad measures that we track is, we know we've got a significantly ageing population. Is our rate of people turning up at ED, being taken to the emergency department or being admitted, are we holding that to the population growth? And in fact, we're seeing that we're managing that at a much lower level. So half the number of people you would expect by just pure population, we've seen that trend starting to turn. So although emergency attendances and admissions are going up overall, for this particular cohort, that older population, we're seeing that flattening down. It's not always easy to say that correlation is causation, but we're hoping that the combination, and that we believe that the combination of all of this activity in our whole system is what's holding that those sorts of key measures. And I think I'll pass back to
Yes,
Tracy to
nearly
just
there.
the
So
last
if we could
couple of
just
slides. Thank
Click
you.
on a slide. So, yeah, thanks, Kate. So I think you can see, hopefully, the work described as sorry, home care. I can't manage my glasses, my microphone and the slide. Kate's particularly gone through the work around that home care, the fantastic work that the PCNs have led around Team Up and the home visiting service, and then the focus on complex discharges and bedded care. And that work is all continuing. As you said, Kate, we're just focusing now on, well, what can we do around the bedded care across health and social care to support people to stay home and get home quicker. Huge improvements in Pathway 1, that domiciliary reablement care and support over the last year that supported that winter performance. So that programme is continuing. Following on from the diagnostic, which we've described in the paper, the Integrated Place Exec has worked up a proposal that all organisations have seen and are considering to accelerate that transformation. Now that's going to require investing in some additional capacity, some external support, and that is under consideration at the moment. We're going to have to bring that to a conclusion in terms of our willingness to commit to a whole system programme at an accelerated pace and how we're going to fund it, and those conversations are ongoing. But I didn't want to lose the fact that the Community Transformation Programme is continuing. Particular focuses around it over the next year picks up brilliantly on Duncan's point earlier on. Duncan and colleagues are now working on how to implement the new primary care strategy and that new model of care that Duncan summarised earlier. That actually, you agree, Duncan, fits really well within this overall Age Well approach and work programme. So that's going to be a really important part of the work going forwards. Kate's already said this term navigation. It's probably not always clinical navigation. It's about navigation. How do we organise ourselves to get people into the right place through a myriad of services that are best suited to meet their particular needs at any one time? And we're working really closely with urgent and emergency care colleagues on developing that across the city and county. You picked up, Councillor Martin, about dementia, and Mark may well want to come in around what's going on around dementia, but only last week, the Integrated Place Exec, we had a particular focus on how the dementia work across the county links into this, because as you say, we've got to be able to diagnose and support people with their specialist dementia challenges, but we've also got a whole group of people who have got physical health challenges alongside their dementia, and we need to be able to manage and support them in a coordinated way. So we're picking that up. And as Kate said, I think whether it's formally through structural integration or just by aligning around shared priorities, shared approaches, pooling resources formally and informally, we can demonstrate now in terms of the impact on citizens' outcomes, the benefits of us working together more closely around this programme. And we want to continue to focus on that infrastructure. It's often organisational boundaries that cause the difficulty for citizens progressing through the care and cause the difficulty for clinicians and professionals to do what's right. It's the fact that I use a different information system to you. It's the fact that I can't plug in and access Wi-Fi in your building, or that you charge me a different rent for coming to that building. We've got to support our clinical and professional colleagues to get that stuff out of the way. We've got to continue this sort of learning by doing, adapting, having a consistent approach around an offer and the outcomes we want to deliver for citizens, but giving control to primary care networks, to local places, to the voluntary sector and to communities themselves about how that is going to work in Derby City, in Bolsover, in Shirebrook, in Swadlincote, etc. And I think the core strands through this that Kate alluded to earlier on are also about making sure that we recognise the contribution of the voluntary sector in all of this work, not just in terms of the insights they can help us gather from our communities, but also the contribution they can make to better services, and ensuring directly that we are hearing from citizens and their experiences, and not just relying on the proxies of the voluntary sector. So in terms of the final slide, the asks of the ICP, it is to acknowledge the work that's been done and the progress, noting the complexity. We're hoping that everybody here feels able to reinforce that ambition around an integrated, multi-partnership, strength-based approach that is developed and delivered locally with communities across Derby and Derbyshire. And particularly, I'll just plug again, the opportunity for us all to commit to accelerating the community transformation programme that's already underway. Thank you.
Right, thank you very much both for that. I did read this and I did think it was a really excellent report. I think perhaps it might be because I've got more familiarity with some of the work that's already happening than I have in some of the other key areas of focus in the ICS. But it did seem very comprehensive to me and very vigorous and full of ideas and ambition. And so, yeah, I think it's a really valuable contribution to the ICP. I've got some points and things I could raise, but and we will go through the recommendations that you've put forward to see if people can sign up to those. But I see that, first of all, I'm going to bring in other people, and Christine Durant. Thank you.
Thank you. Yeah, a really good presentation, covers a lot of ground. I suppose I just wanted to raise an issue from a Chesterfield Borough Council perspective in terms of we're have been heavily involved in a lot of the team up work because we've been providing some of the falls response service, as I think a number of the districts have, and DCHS in some of their instances. I suppose I just wanted to raise as a more strategic point, there's a lot of risk that is being managed within this service, within this approach, and sometimes decisions that individual agencies are making can have significant impact and bring risks on other agencies. And I just think we all need to be really recognise that we just need to have open and upfront conversations about that, because otherwise these things are, not overtly being out there. So, there are some decisions that have been made around the support for our falls response service. Chesterfield Council has decided to take a significant risk and carry on in delivering that service and try to make it work. But actually, it's quite on a knife edge, and it's a big risk for a district council to take. I'm sure the other councils would be in the same bag. So it's not specifically about Chesterfield, but I just think, in moving this forward, there are significant risks that all organisations are taking, and we just need to be really able to have those honest conversations about where that sits.
Thank you, Christine. So before I let Tracy respond to that, if I may add a comment, I think that's a really important point. It's becoming increasingly aware to me, I'm becoming increasingly aware of the fact that, as somebody who's relatively new to this, that there is an incredible will for people to work together and to for the benefit of the people in Derbyshire. I see that as really genuine. I see a lot of genuine effort. But there are lots of crunch points where there are real tensions. And some of these are caused by the pressures on budgets that councils, as critical in local councils, as you know, Christine, an absolute crisis right now. And obviously the requirement on the ICB to reduce its... So I think that my own view on this, for what it's worth, is that I think that it absolutely does need to... It needs not to be the elephant in the room. It needs to be in the room. And but with mindful of the fact that no individuals are deliberately trying to be, well, and most of the time nobody will be trying to be deliberately difficult, and no organisation wants to be deliberately unhelpful, but people are sometimes really struggling with the current budget and service delivery demands that they have. So I just endorse your comment very much, Christine. I don't know whether you're better off in Chesterfield or whether it would be more stressful in Derby at the moment if you were still here. But anyway, Tracy.
Yeah, thanks. Can I endorse it as well? And I think absolutely some of the risks are around money and budgetary constraints. I think there are far broader risks. There are risks about the responsibility that individual organisations, individual professionals and clinicians are taking. And as you work in an integrated way, it's really critical that we can have those open conversations that go far broader than the money. I think through managing over the winter this year, one of the things that we've begun to get better at is being open about the risks and how that feels for individual organisations and getting a transparent... I think if you feel like you're all taking some risks and you're all sharing those risks and nobody is being asked to be in a position where they feel completely out on a limb, we can get through it. But it's far broader than the sort of statutory, financial, even regulatory risk. There's individual risk on professionals, on service providers, on clinicians, and a big strand of this work is around learning by doing and talking honestly and openly about those.
Thank you. Does anybody else want to make a comment on that point before, or is it on this particular point that, okay, so I think Michelle just got in there first and then I'll bring you in, thanks.
Just very quickly, Councillor Martin, absolutely endorse the risk discussion, and I think we have seen as a system how we've articulated and worked together to manage risk, and there's no reason why we can't do that in this way too. And I think we can see through this presentation the amount of risk when you look at that one of those first slides with the 62% of what could be avoided. You know, that's risk. There's risk all in that, and actually, so if we don't do something and we don't continue this transformation programme, we don't try to accelerate it, we're holding a number of risks anyway. And actually, I think we can improve our risk profile by taking this work forward. So yeah, definitely endorse what's happening, but and the plans and the progress, but definitely we need to hold that risk in our mind.
Thank you. So could you just say who you are, please, because I can't see your thing.
Certainly, is it on? Yeah. So Christopher Pienaar, so Voluntary Sector Alliance, representative for Derbyshire. Thank you. So firstly, thank you very much for a very thorough report as well, and for the mention of voluntary sector contribution within that in terms of hospital discharge. We have seen that most of the issues involved in that particular initiative were really issues that didn't need clinical input. I think that's been pointed out already, and that the VCSE have quite a big potential in those types of working, you know, across the board. The ICB focus on transition into or transferring into the community, doing more focus on community. And the GP, we hear about GP numbers reducing, and we can understand that in the focused work. But taking all of that into account, it does show, you know, the big potential for an increased VCSE support, and we're confident in that. Now, the slight, well, it's a big concern, of course, both from service users, but also, you know, those organisations delivering in the VCSE sector. So we hear the information from Nottingham City about the swathing cuts to the VCSE budgets there. We know that meetings have taken, the first meeting has taken place in Derbyshire, and we are very worried that if there are large-scale cuts, that it will significantly reduce the capacity of the VCSE sector to, in terms of prevention and support. We do acknowledge the scale of the problem, you know, that's for certain, that's acknowledged. In terms of the Joined Up Care Derbyshire and Voluntary Sector Memorandum of Understanding, it's laid out clearly in there the integrated services, how these will operate and the principles behind that. And in earlier partnership meetings, we have raised the request, please, wherever possible, to try and co-design cuts so that we can together, as the three pillars, produce the best results in a very tough situation. Perhaps even more reason why we should be doing that. So the action requested is that we as a system get together as soon as possible, you know, to look at that and look at what we can all think about in that respect and how these cuts may be implemented. We also respect the democratic imperative there, but we would strongly request that, please, as a sector. I'll just finish with, you know, the comment from Kate about to consider the VCSE contribution and accelerate the community contribution, and Christine's comment on the impact on other services and the need for conversation. For example, the VCSE leverages in a lot of other investment into the system, so it wouldn't just be those things that are lost, especially if it takes beyond break even and the services crash. Estimated around 40% of, in the latest survey, VCSE sector organizations are operating in reserves. So everyone is facing a crisis. Thank you very much.
Thank you. Did you want to come back on that, Tracy? Or?
Probably not the most appropriate person in terms of it's ICB and the 2 local authorities. I guess I would completely endorse Christopher's plea that we do the really hard work when we're talking about cuts together, just as we do it when we're talking about how we might spend more money, which is always easier.
Thank you. Yes, I need to bring in Councillor Patton. So if your comments aren't directly a response to the comment that's just made, then I'm going to ask you to put your hand down for now. It is a direct response, that's fine, because I know that Councillor Patton's been sitting there waiting patiently to make her point. But I can only comment very generally about the situation in local authorities as far as I know it from Derby, where obviously we feel we're just about staving off bankruptcy. So I've spent a lot of energy personally, along with my cabinet colleagues, in the last 4 months, trying to hold the ship together, and it is really difficult. But I'm not been involved with the part of the budget that deals with the voluntary organisations in Derby. But I mean, if Kim were here, she'd be able to talk more knowledgeably about that. But I do take your point. I think you make a very good point that you should be part of the conversation around the cuts. It is an extremely difficult and unpleasant process with outcomes that we don't want. So it's really not easy. And you refer to what's happened in Nottingham and Derbyshire, and I don't need to tell anybody in this room that Nottingham has been is in a severe crisis, and things happen, and it's not what anybody wants, but it is a consequence of real funding lacks, basically, and so we all do our best. But I'm hearing what you're saying as a Cabinet Member for Health and Adult Care, and I'll certainly take that on board. We have already been through a budget process, and our budget is going to go, first budget is going to go to the Cabinet, I think, next week. As a proposal, but I will certainly feed that back to our Cabinet Member who deals directly with the budget, and then if Kim wants to come back in relation to, I know I'm just talking about Derby, but that's the bit where I've got some influence, then I'm happy to hear from Kim on this particular point. So I'll shut up there. I'm going to take 2 points in response to that comment, and then I am going to let Councillor Patton come in. So I think, Richard, you had your hand up first.
Thank you, Chair. I suppose I make these comments in the context of me living life and finding it more increasingly difficult to convince myself that age is just a number. I think this partnership working together, and everybody is very right. We are having a get-together next week, which you're coming to, Councillor Hart is coming to, other people from the partnership, voluntary sector are coming to. I don't think we describe it as cuts so much but about how do we spend our money in the best way. I think, yes, we can look at it as cuts, but we've also got to look at it about how do we spend the resources and use the resources we've got in the best way they are. So I just would say, yeah, understand that. I endorse the discussion about risk as well, by the way. Risk is a very difficult thing, but we have to manage the risk of transformation So I would say that we're trying to approach this with all our partners in the way of saying, okay, what is the best way of using the resources we've got to the maximum benefit of the people of Derby and Derbyshire? And that's possibly how I would ask people to debate it as well. Inevitably, it means if we prioritise certain things, other things won't get prioritised. We understand that. That's the cuts bit. But those are the hard questions. But the positive hard question to me is, right, how do we use what we've got to deliver the best return?
Thank you, Richard. Is this still on this particular point? I know that you need to come in first, and then are you responding directly to the point that was made before? Yeah, thank you.
Yes, so Jackie Carpenter, I'm the VCSE rep for Derby. I'll try to be very brief. Just want to endorse the fact about co-design with cuts being as important as co-design with investment, because if you include everybody, you get as much more ideas and suggestions from different sectors. Different people have different ideas. And one thing I would say in Derby that was very positive is Marketing Derby held a session about the budget, which I understand was quite well attended. And it was brilliant because it actually explained this is the situation, this is where the cuts are likely to take effect, this is what we're proposing and why. And that's the kind of initiative I'd like to encourage. And I think that was a very, very positive step in the right direction, because actually the VCSE are implicated and involved in every area of every local authority's work. So we're involved, I mean, I'm working in homelessness, this is health and social care and transport, everything really the local authority has involvement in, even in education, if you think about it, they're supporting those things.
Okay, and I just want to add that it is very clear from this report the valuable input you've had to the work that's been outlined. And you want to come in, Carol, and did you still want to comment on this? So I've been Carol, and then I can't remember who's the gentleman over here. I can't. Sorry, Gino, and then I'm going to bring in Councillor Patton.
Yeah, I mean, community voluntary sector. I mean, I mentioned it before, but I mean, it was really just before COVID. We actually at DCC decided, Derbyshire County Council, not Derby City, to do a whole review of our allocations and grants to the voluntary community sector, because we appreciate how much the work they do, but priorities change over the time. So the whole thing was we're holding a whole big review. COVID interrupted that because, you know, there were different pots of money coming in, and the voluntary community sector were really helpful in getting some of the things out that we'd got to deliver. So we're still in that process, but I mean, I would hope that the ones that we work with in Derbyshire, we are trying to communicate with them. We are trying to look at where we've got to, you know, spend our money on the priorities and how we can work with them, and they work with us to actually help us deliver. We realise how important the sector is. We can't manage without it, you know. So, but there has been an awful lot of work, but it started even before the real pressures on the budget. We started looking at that, so that was really quite helpful. So, yeah, we have got to prioritise. We do realise that we are going to be stretched with finances, and that is all the more crucial that we do work together. Yeah, so there's a lot of work going on with the organisations. Have been, as I say, COVID interrupted, but again, I think that actually emphasised just what the community and voluntary sector can do and how they can help you deliver. So it really raised the bar again. So, yeah.
No, absolutely, I totally agree, Carol. Gino, and then I'm going to bring in Councillor Patton.
Thank you, Chair. So Gino Di Stefano, Director of Strategy at UHDB. If I may, Chair, I'd start with a thanks to Tracy and Kate for their leadership in this space. I think it's hugely important, and completely endorse the kind of recommendation to our group around going further faster as one of the next steps. But completely hear the point about the need to redistribute resources. We know there's going to be no significant investment into the system anytime soon, even though that's challenging to do in a practical sense, given the inevitable tension between organisational leaders trying to look after the bottom line as, I guess, sovereign organisations, as well as trying to provide system leadership at the same time. But just to again, further endorse the points that have been made about this, the need to strengthen community services as a whole and rebalancing what's been a decade or more kind of skewed investment into hospital services. And I say this talking from a hospital perspective. We'll always argue we need more in hospital services, but we certainly endorse the proposal to redistribute and strengthen community services because the case is strong. Our board, like other partners, is reviewing the proposal in March, but right now we think strategically this is the right thing to do. Thank you, Chair.
Thank you very much. I mean, that is an interesting, I think that's a slightly different comment, if I may say so, Gino, but it's a very important comment, but I am not going to let Tracy come back on that because I need to bring in Councillor Patton right now. Thank you.
The question was, it was regarding the falls and how you're going to deal with that. So just a couple of questions. One was, will you be employing more staff to deal with the new structure that you're having, or is it utilisation of existing? And the second one, will you be operating any sort of out-of-hours service, or is it going to be strictly within you know, a normal working day? Because as we know that lots of these falls happen at the weekends, and if you end up then ringing 999 to come and get you out, it sort of defeats the object of trying to deal with the situation. Thank you.
Yeah, I'd probably need colleagues to get into real detail of this, but it's a bit of both in terms of the existing and new, because we knew there were some services, particularly across the county, in existence ahead, and in some areas, because you can't plan when you're trying to have a local service, there's not lots of people falling every day for whom they don't need some service, and a local response is sufficient. So what we've tried to do is to use where there are existing people employed in an area, and that might be through the districts and boroughs in that patch, that might be a housing association provision, it might be community services, and that's where we've had local, the discussion has been at that local level to say, in your patch, who are the people who are available, who could respond should that call come, and therefore how do we set that up, and recognising that's going to need a level of investment, so it's a bit of a redistribution of some of the existing resource, but a sort of topping up of some of that to make sure that there's enough, it can cover it. So it's back to that learning by doing. We're testing that approach out. We did have an approach before where it was a sort of a payment by if somebody did respond, but then it gets so small a number that people can't put provision in there. So we're testing that out, but we're trying to build on what there is, recognising it needs a bit of a top-up to make sure it's consistent. And in terms of the operating, I think it's 8 till 8, 7 days a week. So, but I'd need to confirm. But it's not 9 to 5 certainly. Yeah. Thank you.
Thank you. I'm sure there is some people in the room are very happy to hear you say that we need to focus more on the community services and not just exclusively on hospital services, and that's clearly a good mood. And I fully recognise the importance of these services and the value of them, and the work that's already been done towards working more effectively together, and then also the importance you're placing on improving on that work and transforming the services. So we'll come back to that when we look at the recommendations. And so them saying that, what I'm about to say doesn't for one moment challenge the importance of the work that's happening in this report. But what I would say is that it's still a service orientation, isn't it? It's still about offering people services when they need it. And so, if I may, with respect, could I turn to Robin and Ellie as the Directors of Public Health even, because my question would be in terms of ageing well, most of us, I mean, it's probably pie in the sky stuff, but to a large extent, we'd like to age well without having to draw upon full services or try and get to see the GP every week or spend 3 days a week at 8 o'clock on the phone. We'd like to age well in the sense of not needing medical services. And so I know I'm not trying to put you on the spot, but I think it is an important aspect of what we generally, the way we generally approach things in public health. So, and I don't think it's particularly part of this report. So is there any thing that you could say about that in terms of the integrated care strategy overall and the way it feeds into this and this need to, you know, literally take people away from needing medical or services at all?
Thank you. So, and I have been thinking about this during the presentation as well. So, as you were talking about earlier, actually, we've got a larger number of people who are going to be living in ill health in later life, haven't we? And one of the things that we do know, and I was just looking at, is that if you think about dementia as being a really significant burden, particularly for the future to manage, is around 40% of the cases of dementia are actually preventable. And that links really nicely with our other streams within the integrated care strategy. So one of the ways of delaying or preventing dementia is actually ensuring that people are educated to a high level. So the more that you're educated in your early years, the more protective that is in your later years around the development of dementia. And then from the stay well aspect of the strategy, it links also really well. So the Lancet, which I've just got open here, they've got 12 areas that you can impact to reduce the risk of dementia. That would also reduce your risk of cardiovascular disease as well, that links into the strategy. So, and just looking at it now, treating hypertension, stopping smoking, reducing obesity, taking frequent exercise, you know, they're all really similar actions that we can take that help us to keep a healthy brain and also keep a healthy heart. And of course, those aspects, particularly around exercise, are really helpful from the falls prevention perspective as well, keeping that muscular strength. So there's lots of different things we can take throughout our life to actually get us to a point of ageing well. If there's anything.
So I think there's a fair amount of work.
Could you put your mic on, please?
Sorry, have I got one behind me? Yeah. Oh, there we go. Sorry, I was just there you go. I think there's a fair amount of work going on around sort of ageing well in that preventative space in terms of the public health agenda, and looking at things like age-friendly communities, for example, and thinking about what we need as we age. But I agree with Robin that it's about joining up the conversations as well and joining up the pathways so that we can see those preventative elements and we can see where the gaps are or where we might need to do more around promoting some of those health protecting behaviours that, you know, we need people to kind of be able to do to look after their health. So I think it's about joining some of that up, and the strategy does some of that, as Robin's described. So if you take the stay well element, then there are big parts of that actually contribute to supporting people to age well, but perhaps we don't tell the story of that as effectively as we could. And if we did that, then we would be able to better see where we might need to put more of our efforts.
Thank you. Yeah, it seems to me that in addition to this work that's outlined here, we perhaps need to think a little bit more, Robin, about that and that you've just outlined, and then also perhaps in Derby, I can't speak for Derbyshire, but perhaps a bit about the dementia strategy. I believe you have a dementia strategy in Derbyshire, is that correct? Yes. Sorry, and I'm not sure we have a specific strategy in Derby, do we? Or perhaps, I don't know, maybe need one, but I think it's a conversation to have, be outside this meeting. I think it's something we ought to come back to, because it's just such an enormous area and it's going to become more and more and more significant. So is that okay, Ron? Would you agree with that thing? And then the other point, if I could make another point, is that the other area where I think we probably need to look at more, and I think you gestured towards this, Tracy, is the issue of palliative and end-of-life care. I've had some excellent briefings from some of these charities who work in these areas, and I was informed, and I suspect you'll confirm this is correct, if this is correct, that it's only just become a statutory duty to provide palliative and end-of-life care. Is that correct? I don't know. That's what I was told anyway. But I think, anyway, the point I'm trying to make is that whether or not it's statutory or not, it is something that you talk about a little bit here, but maybe it's something that the ICP needs to expand upon. There's so much in here, but it is going to become, it is very important. It's going to be increasingly important.
Just on that, I know that the Joined Up Care Derbyshire End of Life group would be absolutely delighted, Councillor Martin, to have a focus on that in a future meeting. So again, all of our organisations are involved working together across the ICS on end of life care, and we've tucked it in here. It does have a clear focus through our two places, but actually I know they'd be delighted to receive an invitation. And just on your earlier point, I think it's not by accident, is it, Robin and Ellie, that actually the strategy is start well, stay well and age well. And I guess the preventative strands have to run through all ages of the way in which we support people. But actually, you know, if we get the start well right, that will turbocharge our young people into a much healthier adulthood. If we get the stay well bit right, we're going to turbocharge, kicking all of us, because we're all of an age, into a much healthier aging well. So, you know, you never know, in 30 years' time, we might not need a dedicated age well section of our strategy.
I think that is highly unlikely, if I may say, but anyway, because there are always ways of ageing even better, aren't there, or whatever. But Mark, you want to come?
Yeah, thank you. I'm not quite sure how to follow the ambition of the moving that middle bit out, Tracy. But just two quick things. So there was a bit of work done a few years ago around the dementia strategy, and it might be worth us just revisiting some of that across the system. Obviously, really important that we get the right focus on that. And clearly there's a link with end-of-life care there as well at one point or another. I just wanted to pick up the dementia diagnosis question that you raised earlier. So there is some incremental good news with our dementia diagnosis rates increasing across Derby and Derbyshire. So it's worth remembering that the memory assessment service, which is where the diagnosis normally happens through that service, was one of the services that got stopped during COVID, and all those staff were moved to other areas to support. So there's been quite a significant backlog because of that during the COVID period, which means that we're on a bit of a catch-up to make sure that we're seeing people to either get the diagnosis if there is one, or indeed if there isn't as well. So we're up to about 68-69%, I think, at the moment in terms of the diagnosis rate, which was higher than the expectation. But it's worth remembering that's a percentage of a bigger group of people. So really good incremental progress in respect of just trying to catch up for the last 2 or 3 years of the post-COVID issues of the memory assessment service in particular. Obviously not seeing people, and then there are really good partnerships around what happens next after somebody is diagnosed. And again, there's colleagues that provide a service through the voluntary and community sector as well as through healthcare providers as well. So that's one small part of the overall dementia strategy, but some really sort of significant small steps being made post-COVID.
Thank you, Mark. And this isn't a conversation for now, actually, but I think another thing that's really important is focusing on how organisations communicate where people can find assistance, because that's the point that is constantly I'm being asked constantly as a councillor, is where do I go? Where do I start? How do I find out about how I can get help? And I know we're focusing on that in Derby, but I think that's also really important as part of this. Anyway, do we have any further comments on this particular? Yes, please.
Thank you. So just again to commend especially point 2, the integrated multi-partnership strength-based approaches. This is wonderful to see. It's gone on in the past, but we've seen in these meetings, you know, a wonderful reception of these ways of working. It's been really good to see. Now, just on the design query, one point, place-based geographies. We have discussed this quite a lot in these meetings, and it's been agreed, so I won't go into it, but there's a point there about place-based and missing out interest-based, because especially in health, we are looking at the leadership of those with lived experience, not just participation and consultation, but leadership. And so those different types of communities of interest with different conditions, it is very important that it's recognised through that condition. You know, for example, age, whatever, you know, aging well, that those communities are in a driving seat, and by not by saying only place, we run the risk of losing storehouses of knowledge of organisations working in that as well, because it's only looked at the place level. So there's the county-place partnerships. But I think from a design perspective, it's a really important point. Thank you.
Thank you. Very quickly, because we need to move on, I think, but Kate, did you want to respond to that?
Thank you. No, you always do. Thank you.
Or Trace?
Thank you.
I think it's just to acknowledge that valuable point, and I think we've probably focused, as you picked up quite rightly, on some of that integrated service delivery, and we're thinking geographies in terms of services, but in terms of certainly the planning, the co-design, we absolutely have to take that whole interest, and the work that the VCSE did do, bringing those organisations, some of which were whole system together, was so valuable. So it's a really good point, and apologies that we'd sort of not noted that on here. Thank you.
Okay, thank you. Well, there is an awful lot to cover on this, and I think we've only just really scratched the surface, but I have given it an hour, and so I'm probably going to draw it to a close now. But as with all these areas, we will and can come back to them. So, just in terms of the recommendations, you can see them on page 1 of the report. Is the meeting happy to endorse those recommendations? I see nods around the room. Okay, well, I thank you for your contribution to talking to this report. I'm just going to pause the meeting there until 3 o'clock so that people can have a comfort break and also get more refreshments if they need them. And then we'll return to the items. Thank you. Okay, welcome back to the Integrated Care Partnership meeting. Thank you very much. Our next item is a report from Linda Garnett, who is the Interim Derby and Derbyshire Integrated Care Board Chief People Officer. And her report is on developing a health and care workforce approach. So Linda, thank you.
Thank you very much. Good afternoon, everybody. So I'd just like to start by introducing myself and my colleague who's with me this afternoon. So yes, as Councillor Martin said, I'm Linda Garnett. I'm the Interim ICB Chief People Officer. So in that role, I'm a member of the executive team and a member of the board for the Integrated Care Board in Derby and Derbyshire. And my focus is very much within the NHS family, working with our provider trusts, but also working with our wider partners on everything to do with people and culture. So that's my role. And I'd just like to introduce Susan Spray. So Susan.
Thank you. Susan Spray, I'm the programme lead for the Joined Up Careers venture, which is a system partnership working with all partners around system-wide recruitment and resourcing activity, as well as anchor development programmes.
Thanks, Susan. So the reason for us coming this afternoon is really to share with you some thinking and some proposals around a shared programme of work for the Integrated Care Partnership partners. If you could go on to the next slide, thank you. Thanks. So, as an integrated care system, there is an expectation on us from NHS England, which was written down in the guidance when integrated care systems were first established. And what we're asked to do is for NHS leaders and organisations to work together to deliver 10 outcomes-based functions with their partners in the ICS to make the local area a better place to live and work for their people. And I've attached those 10 functions as the appendix. When you have a look at them, there's nothing to disagree with in any of those functions. They're all really valuable, important functions. So they include things like talent management, leadership development, health and well-being of our workforce, all really valuable things. What I don't think it reflects is the reality that we actually work in as an integrated care system. So we have literally hundreds of sovereign organisations who employ their own staff. They range from less than 10 employees right through to over 13,000 employees in the case of UHDB. We have very different terms and conditions and pay bargaining arrangements across those different organisations. We've already heard today of the significant financial challenges in all the sectors, and there are very different levels of investment in workforce infrastructure. So you'll go from organisations where there's quite a significant HR function to organisations where there's nothing at all. And I think it's fair to say within the current people and culture governance within the ICS, it's very heavily weighted towards NHS issues and priorities. So that's the context. When I started doing this role back in April, Chris Clayton asked me to give some thought as to how we could begin to shift some of that and to make some progress around doing more on people and culture that wasn't just focused on the NHS workforce, and to think about how we could move into that joint workspace. I've had quite a number of conversations with various people. A number of them are here today. So Simon, Tracy, Andy Smith, about what might a shared programme of work in this space look like. So if you'd like to just move on to the next slides. I just included these not to go through in a lot of detail, but just to give you the background that probably over the last 18 months, since the ICB was established, and indeed before, we do have a track record of working collaboratively on a range of people and culture related work. It's tended to be led by the NHS, it's tended to focus on NHS issues, but we've always tried to be inclusive and to extend an invitation to other partners to work with us as and when it seemed helpful or appropriate for them. And we've done some really good joint work on health and wellbeing of the workforce, which has included all partners. We're doing some good work on leadership development, which covers all partners, but they're quite small areas. So if you could just move on. So just skip over the next slide and go on to the next one. So what we've thought about is, how could we shift that focus and shift that emphasis? And what we'd like to suggest is that we pick out 2 of those 10 functions for the ICS, which have a more clear linkage to the ICP ambitions and strategy. And those 2 functions are functions 2 and 7, which is growing the workforce for the future and enabling adequate workforce supply, and driving and supporting broader social and economic development. Those seemed to us that those were things that everybody was going to have an interest in, and were areas where we could look to do more together. The other thing that we'd like to suggest is to look at the governance within the ICS and to try and make a stronger connection into the ICS executive and the integrated care partnership around people and culture issues. Because we don't have a forum to do that at the moment, and what we would like to do is to establish a new group, a health and care workforce partnership group, which would oversee the delivery of that shared work programme, and for that group to be accountable to the integrated care partnership through the ICS executive. If you could just move on to the next slide, Alison, thank you. So, in terms of what that joint programme might look like, I'm going to hand over to Susan in a minute to just kind of say a little bit more about this and to give you some examples of the kind of work that we have been doing already. But there's 2 main areas where we think that there could be real benefit in us working together. The first one is around the anchor projects type of work. So looking at widening access to work. It was interesting, a couple of people have referenced the session that we had this morning with Robin and Ellie talking about health inequalities, and we know how important having access to good work is for very many things, but that seems to us a particular area where we could do more. And there's a number of pieces of work that we're already thinking about or doing, which Susan can say a little bit more about in a minute. One area I'm really interested in us looking at is a more progressive recruitment policy. So trying to move away from thinking about when we recruit people, who's the best person for this job. Instead, thinking about what's the best job for this person, and taking a really different and much more inclusive and progressive approach to really enabling much more access into work. And then the other area that we'd like to do more on and to have as part of our shared programme is around the constant issue that we all face about recruiting people into work. And we've spoken many times about we don't want to rob Peter to pay Paul, we don't want to have staff just moving around and jumping for a few pence more on their rate, although we know that happens. Can we take a more joined up approach to looking at how we recruit and bring in and think about that as a system asset, and think about that both from the way in which we need to recruit people to deliver the services that our communities need, but also much more about seeing that as part of the social development and economic development of those places. So I was just going to hand over to Susan just to give you just a few examples of some of the work that we've been doing, just to kind of bring that to life a bit.
Thank you. Yeah, so just to elaborate really and to bring to life some of the initiatives that sit within both of those objectives. So first of all, just to sort of bring everybody up to speed with regards to that we are a system-wide partnership. So we are funded centrally through the Better Care Fund, and we have received that funding commitment since 2018. So we have got a central resource that's hosted and employed by the Integrated Care Board, but our programme of work expands to the entire health and social care sector. So all of the programmes of work that we've been doing are inclusive of those organisations. That being said, there is still an opportunity and a desire to amplify that programme of work to some of our smaller provider organisations, and I'll talk a little bit more about how we intend to do that. But first of all, just to give you some insight into some of the programmes that sit within the anchor development work. So our key sort of focus for the past couple of years has been around building healthier communities, delivering solutions to socio-economic needs. So we've been working closely with local community groups, the Department of Work and Pensions, so for those individuals that are economically inactive, we've been providing opportunities for them to access opportunities to good work and to retain that work. So developing a model where we have got our breadth of entry-level vacancies, which we are continuing to struggle to fill. We've been taking those opportunities to those individuals and providing meaningful conversations, career coaching, guaranteeing job interviews, and we've been doing that across a breadth of different cohorts, so inclusive of refugee groups, individuals that are leaving the care sector, and other sort of underrepresented and disadvantaged groups. In terms of the system-wide recruitment campaign, so again, we've got organisations that are doing the bulk of their recruitment at organisational level, which we will see that will continue. But our opportunity is around the system-wide collaboration for recruiting as one health and social care workforce. So through a variety of different opportunities, we've had the opportunity to build recruitment campaigns to bolster our workforce. So the most recent example of that would be the Derbyshire reservist workforce that we have been actively recruiting to. We are continually engaging with our future workforce in terms of our local health and social care students to ensure that we are actively engaging and ensuring that they've got opportunities to enter into our employment on completion of their course and their programmes. To build a framework around all of this work, we want to strengthen the work programme, and as a commitment to the partnership working around the entire recruitment and retention agenda, we have developed a health and social care good employment charter, and that's attached within the papers that you've got today. What we're asking for providers to sign up to in regards to that charter is a set of pledges and commitments with regards to good employment and workforce development to ensure that we are working collectively around improving the image of the sector, that we are supporting those that are in our employment with workforce development, increasing the number of apprenticeships, better utilisation of the apprenticeship levy to support their career progression and development, and ultimately to retain that workforce. So I think with commitment and support from members of this group, we would like to build upon that charter, socialise that more so with our smaller provider organisations, so that we're able to share that best practice from our larger employers into those smaller SME organisations.
Thanks, Susan. Thank you. Could you just move on to the next slide? So I hope this doesn't look too complicated, but I just wanted to just illustrate to you just this idea about establishing this health and care workforce partnership group and where that would sit within the overall governance. So as you can see, it would have a connection into the People Services Collaborative Board and the Provider Collaborative Leadership Board, but its main focus would be up into the Integrated Care Partnership and the ICS Executive, but it's got that connectivity across both health and social care. So I just wanted to kind of illustrate that to you. If you could just move on to the next slide. So I guess what we're asking for today is a mandate from the Integrated Care Partnership to progress this joint work programme. As Susan said, we'd like to propose that we do just revisit and socialise that workforce charter. I think it was, is it about 12, 18 months ago?
It's probably more like 18 months
yeah,
to 2
about
years.
18 months to 2 years. I mean, it's a really good document and has got a lot of, had buy-in from the different organisations, but somehow I think it's gone a bit below the radar, and it feels to me as if it's, you know, it's something that says everything we would like to do. So rather than reinvent the wheel, I think we could just revitalise that and socialise it. And then be really good to get any thoughts you've got on the Workforce Partnership Group. Are you content for us to go ahead and establish that? Any steer you'd like to give in terms of the terms of reference, the membership? I'd really like it to have a strong non-HS membership. Yeah, it'll have some NHS membership, but I think it'll be mainly other partners, and be really good to maybe have a chair chosen from among other partners. So that's the end of our presentation, Councillor Martin. Thank you for that, and happy to take any comments or questions.
Okay, thank you. Yes, another really excellent presentation, and this is such an important area, I know, from what's happening in Derby and elsewhere. So do we have any comments, please, and responses to the requests put by Linda and Susan? Michelle?
Yeah, thanks, Councillor Martin. I'd wholeheartedly, endorse the proposal, to be honest. I think, given the conversation the ICB board had this morning, and particularly around health inequalities and the requirement really in terms of improving that around economics and meaningful employment is so critical in health, and we've got huge challenges across health and social care around our workforce. Marrying these two things together makes absolute perfect sense. So absolutely endorse it from the ICB.
Thank you. Christine from Chesterfield Borough Council.
Thank you. Just to say thank you for the presentation. And from a Chesterfield perspective, we've been engaging with Susan Spray and people from her team. Very specifically, we've got a skills action plan. So together with Sharon Gibbs, who's our place lead, and the Borough Council, and we've got the university and we've got the college and a number of other people around the table. So from a Chesterfield perspective, we are kind of focused on that from a place perspective. So, and I think we're doing and engaging at the level we need to. So I suppose I'm comfortable if partners, feel at a Derbyshire level that the need for a workforce partnership group. But I think if we've got limited resources from a district perspective, I'd prefer to be focusing at that level. I'd welcome comments as to whether you think, Derbyshire-wide organisations have got the resources to focus at place level, but it's much easier for us, obviously. I'm just concerned, if you have a workforce partnership group and there's an expectation there's a representative from each place, whether that's a local authority or NHS or whatever, then it could become quite a large group. So I don't really know quite what your thinking is, but I do agree a strategic approach to it. And if this group gives you that, then great. I think I'd prefer from a district perspective that we work at our place level.
Could I come back on that?
Yeah.
I think I agree with you, Christine. Susan and I have already spoken, actually. I think the work that you're doing in Chesterfield's really excellent, and we would like to kind of share it with others as a bit of an exemplar of the way you've approached that. I think it's great. And I don't think we did have an expectation that we would have representation from each place at this group. I think we need to think about how do we make sure we're not reinventing the wheel, but and not duplicating. But I think I see this group as much more of a sort of, as you said, a strategic oversight group, and drawing in from places and then enabling and coordinating when it's appropriate. So yeah, thank you for that, Christine.
Thank you. At the back there, thank you.
Yeah, just to say again that this is a very welcome discussion and very important. And the voluntary sector, we have a task group, a cross-partner task group, and we would hope to build on that, because as well as the paid workforce, there's also the volunteer workforce as well. And again, this is where it's not just one sector's problem, is it? It's the whole city and it's the whole county's problem, just like it is with the budget. We have to all look at it together and all bring our contributions. So I don't particularly have a view about what level you want it, but I think it would be useful to have some voluntary sector representation. Perhaps we can have a discussion afterwards about this, about what's the best way to do that, to achieve that, that's workable for you, but also workable for voluntary sector reps.
That would be great, Jackie. I think what we'd envisaged, we put in terms of reference, there would be, I think we've put representation from the Voluntary Sector Alliance, but to be determined how that would work best. So, yeah, agree with you.
Thank you. Do we have a view from Derbyshire and Derby?
Thank you, Chair. Yeah, I mean, Linda's already referenced, we've had conversations about this. We're completely signed up to the concept from a Derbyshire perspective. I think it does need to be a higher level than for that workforce partnership group, so that you've got the more strategic thinking level approach into that. But yeah, we're signed up to it, like others have said already. I don't want to repeat everybody else, but one of the biggest risks we've got is around we mentioned risk earlier. One of the biggest risks we've got is around the workforce capacity and the insufficiency of that across the board, whether that's volunteer workforce or paid workforce. So the only way to manage that risk is to do the collaborative approach. So yeah, absolutely signed up to it.
Thank you very much. To make a comment on this.
Thank you. So I was just going to pick up on the health inequalities part of the conversation, and just really positive to see that thinking about the recruitment processes, thinking about how young people who perhaps haven't been able to achieve some minimum requirements can be supported into work, how perhaps talent rather than qualification can be assessed for young people to take them into work, and particularly thinking about apprenticeships, and particularly degree apprenticeships, as a way of ensuring that those degree level qualifications are much more accessible to young people locally. So I think it's really, really positive.
Mark, thank you. Robin.
Yeah, thank you. Two quick points. So certainly supportive of a strategic approach. I'd have a bit of a plea as to, is there any other meetings we could get rid of to free up the time for folks to spend a bit of time with doing this?
Mark,
so
we're on that. We've got rid of one.
It's my hobby horse. So free up some time. And I wonder whether there's an opportunity to bring in service users and experts by experience who are looking for work as well. So I know we've obviously got some through mental health, but more broadly, when we're talking about volunteers and or paid work, people who have used our services have also got fantastic experiences that it would be good to bring them into our workforce as well. So I'd welcome the opportunity to sort of integrate some of that into this as well.
Yeah, really, really open to that. And I know you've done some work, haven't you, Susan, with some of the teams in the Mental Health Trust who are working with bringing people into work, that we've got quite a strong connection with that. So, yeah, really happy to do that. Thanks for that, Mark.
Thank you. And Susan, can I just ask you to turn your mic off, please, because it makes everybody else a bit quiet. Okay, I'm mindful of time, and some people have to go. So are we, I'm getting the feeling that the room is happy to accept these three recommendations with the provisos that have been articulated in the room. Is that the case? Do we have support for this proposal? We do from the ICB, Derbyshire, from Derby, and the qualified, the potential support from Chesterfield, the Hospital Trust. So we're happy to accept this. Yeah, I see everybody nodding. I see Duncan sitting quietly at the back, not responding. Are you happy? No, I get a nod from at the back there. Good. Okay, brilliant. Okay. Well, thank you very much for that report. I could have some comments on it, but I might try and catch you afterwards very quickly. I'm mindful of time, so we will move on now.
Thanks
Thank you
very
very
much,
much for that. It's a positive development. Right, the next report is on coming back from what we the report we had before, which was on the Staywell agenda, wasn't it? And some investigation into data sharing, which we requested. I think I've spoken to Alison Wynne. Are you going to present this, Alison?
I am.
Yeah.
Yes.
And I understand that this is a kind of interim report. So, Alison, that's the status you feel it has. So you may not be able to answer all the questions fully at the moment. So there'll be more coming back from this. But Alison, do you want to speak to it?
Yeah, thank you, Chair. And yeah, part of that is because Leah, who's our kind of IG expert, isn't able to attend today. So I'm not going to attempt to cover off any of the really technical elements of the report. And as you'll see from the authorship, quite a range of people and their kind of technical expertise is linking into this. So I'll take kind of us through the report fairly briefly. And as you've mentioned, this report came out of the Staywell update last time and the potential opportunity of using a Section 251 agreement to support our data sharing arrangements and ability to do things like a population health management work. So that is why the report is here. I think with some of the work that we've done in between times, so since that last meeting, I think we recognise now that Section 251 in and of itself won't resolve all our issues, but may well be a key component of supporting us in our work. If it is appropriate to use a Section 251, there will need to be further work to complete the application, and that includes an overview of the data infrastructure, the platform and tools that we'll use to support data sharing, the storage of the data and the analysis of the data. So it's a little bit chicken and egg. We need to have all those things lined up to be able to put in an appropriate Section 251 application. I think at the minute, I don't think we have a full oversight of the data that's already being shared within the system and the range of infrastructures, tools and platforms that we have, and some of the opportunities that we could potentially maximise out of those with the right arrangements in place to support that. I think another thing we need to consider is having some real clarity on the system asks and actually what do we want and need to be able to do but are not currently able to do, and how far we can take kind of the arrangements and the systems that we have in place at the moment to support that, and then where have we've got remaining gaps. So I suppose that leads on to the primary ask within the recommendations was around support for the ICP for us to do some further work in gap analysis to understanding exactly what do we need to fill, and then thinking about the best arrangements and approaches to do that. So, Chair, that's a really swift, I think, kind of taking through, and then obviously
skimming over rather a lot of technical issues. But yeah, that's fundamentally the ask of the board today.
Thank you, Alison. I appreciate that we might have been able to cover more here, but unfortunately can't be here. So, Richard, did you want?
Yeah, thank you, Chair. I just wanted to say, yeah, in principle, support this. Nottinghamshire have already got a 251. I've been and had a quick look at what it means. So, subject to the work that's got to be done, I have to say I support this fully. That's certainly the direction forward.
Thank you, Richard. And I think it is noted in the report that the intention is to meet with our kind of Nottinghamshire colleagues and understand kind of what process they've gone through and what the Section 251 is supporting them with.
I had a look at the advantages that Nottinghamshire thought it brought to them, and you know, if we can get the same advantages, if that stacks up, yeah, it's definitely an advantage.
Thank you. Any other comments, Tracy?
Yeah, just from a D3B perspective, the board that looks at the digital technology as well as the data stuff fully support the requirement to have the Section 251 necessary but not sufficient, as you've said, Alison. My question was, will it be SIG, the Strategic Intelligence Group, who lead this with the IG bit? Because it's as much about what information we're going to need and how we want to use it as it is actually about the technicalities of the information governance.
Yeah, I think it's probably kind of all those elements. So I would see and we'll be taking kind of that request through to SIG, and I've shared the paper with colleagues, and some of the colleagues are on that paper. So I think they will be the primary group that will lead on it, but obviously we'll need to link into D3B for some of the technical implications, but also to the Derbyshire IG board from their input as well. And I think it's probably something we've not done well historically, is linking kind of the IT, the IG, and the kind of data users and needs together. So I think that's kind of the elements of the system that we need to bring in to support actually doing this piece of work.
Thank you. Any other comments on this at this stage? No. So we're not actually, if we agree to the recommendation for a gap analysis, we're not at a point where we're agreeing to anything concrete at this stage, just for an analysis. Because I would also have some questions about, patient confidentiality, etc. But perhaps that's more appropriate for next time. So, are we all in the room happy to agree to the three recommendations under 2.1, 2.2 and 2.3? I mean, crucially, are we all in agreement of, fundamentally, to support the gap analysis of current resources? Yes, getting some nods in the room. Okay, right, thank you very much. Thanks, Alison, for that. So that's agreed. Right, our next item is an update report from Jane Needham on the Stay Well agenda. Thank you.
Apologies, Chair, I don't think Jane is with us today, but I can put my hand up if that's okay to very briefly take us through. The report is for the information of the board, so it's not asking for any decision. So just very briefly, just to note that the first part of the report really just summarises kind of where work has got to date, and I think most of that was updated to this board at the last meeting. But if I take us through to the second page of the report from 4.5, I think it gives a bit more of an indication of where things are going. So the Sprint Coordination Group, and I think we referenced, again, Jane picked up previously, has got 3 subgroups: communications, strategy and delivery, and all those groups continue to take work forward. And I think particularly the communications group, I think, is really establishing really strong relationships and working, and I think the intention is that will go beyond the existing sprint around smoking and kind of will have some longevity in and of its self there. just to note as well that the evaluation, I think, that was referenced last time around the sprint approach, that's intended to be concluded this month, so we'll be able to bring an update at one of the future meetings of this board to give an overview of kind of the findings of that and what's worked well and what could be better. Some of the achievements of the work are highlighted under 4.7, and then just taking us into kind of the next phase of work. So the Population Health Management Steering Group is now actively considering what will the focus be as we come to an end with the smoking cessation, and that takes on into the Tobacco Delivery Board, kind of what will we be focusing on next. So that was part of the focus of the last meeting, and certainly the next one. So we'll be able to again report what that focus will be. And then finally, just to note that group has also have been looking at and supporting kind of the work around the proposed objectives to support the delivery of the joint forward plan. So we've been actively involved in that. So I think that's be sufficient to report on this time, and obviously be a fuller update at a future meeting. Thank you, Chair.
Thank you, Alison. Would anybody else like to comment on this update? No? Okay, so just for me to say thank you very much for this work. I do think it's important for the smoking cessation agenda, and also in terms of the modelling of more integrated working. And we know that the data sharing is also coming out of this. So I think we'll just look forward to receiving some evaluation. And in the spirit of Richard, I think would that evaluation also include some sort of, some feedback, however tentative initially, on the sort of impact this has had actually on the population rather than just the working within professionals, because I know that Tracy and Jane's report also very helpfully talked about evaluating the impacts and having quite a strategic approach to that, and using various services, wasn't it, to do that. So I know that is has been stated as an important part of what we're trying to do, is actually measuring outcomes, which isn't always easy, and is kind of difficult and expensive to do. But so will that be part of it, Alison?
Do you want to come in, Ruth?
So just on the tobacco sprint, I think the purpose of that is to kickstart some work across the system rather than being an end point. So I think, yes, we want to see what the outcomes of the sprint itself are, and that approach to kind of having some focused energy on a particular topic for a particular period. But I just wanted to kind of make the point that there is additional resource coming into Derbyshire from central government around stop smoking. We have agreed at this board that stop smoking is the priority area that we want to focus on, not just for the duration of the sprint, but for a longer period of time. And I think there's an intention next week at the planning session of the Integrated Care Board and system to look at what that means, and then to bring that back here. So I think what we'd expect is, rather than a kind of set of these are the things we've delivered through the sprint in that way, that it sets the foundations for then us to set a greater ambition for the system and really put some tangible actions around how we're going to deliver on that.
Okay, right. Thank you for that, Ellie. That's excellent. Thank you. Yeah, it was made clear at the outset that the sort of sprint was had sort of a certain specified aim, but we just need to keep asking that question of how can we evaluate outcomes, and I know it's often quite resource intensive to do that. But anyway, thank you for that, and thank you very much for that report, Alison, or speaking to it. And then we just have a moment from you on the Integrated Care Partnership and the forward plan.
Yeah, thank you. I won't take us in any detail through that. Obviously, the kind of items that have come forward, or we've got as standing items, are listed in the future agenda, and I think there's a few things to come up today that we'll need to pencil into future meetings, so we'll do that. But one thing to note, which I did neglect to put in the forward plan, was that all of you should have received an invitation for an LGA facilitated development session between the ICP and the two health and wellbeing boards. And that's on the 29th of February, so hopefully you've all had an invitation to that, and I really appreciate you prioritising kind of busy diaries for that, because I think it will be a really valuable and useful event. So just wanted to note that, Chair, because I did neglect to put it into into the paper.
Yes, thank you. And just to add to that, I spoke to Alison and we've had an initial pre-meeting around that, haven't we? And it was very clear that one part of that, an aspect of that agenda is very much putting out there, putting on the table, difficult issues and where there may be tension. So trying to take a very realistic approach to what the challenges are, rather than just speaking in very, well-meaning tones that don't, that is obviously a requirement, but it's also need to recognise what the realities of the difficulties are, and that is on the agenda for that day, along with many other things, no doubt. So I hope people will feel able to attend that. I know that everybody here is extremely busy, difficult jobs, or difficult volunteering coordination roles. Okay, so if there's nothing else, Richard.
Sorry, Chair, really quickly. Can I ask if at a future meeting, can I bring a paper, well, can the ICB bring a paper around the consultation with the population that we're doing through the Insight programme? I think it's worth the ICP seeing this, because I think it's an area where, when I've looked at it, we probably need to coordinate a little bit about how we do consult and feedback from the population, because I suspect we're all doing a bit, and it probably needs an ICP approach to it. I think the Insight one is a really interesting way to kick that off, and with your permission, I'd like to bring probably a couple of people maybe to the next meeting or the meeting after that, just to give a paper on it and a sort of status of what we're doing. So you get an opportunity for you to have a look at that and think about it alongside what you're doing, and maybe how we do it in the future. Because I think there's a potential here that we might be duplicating, wasting resource, you know what I mean? And it needs to be really focused. And we need one message, one population, if you know what I mean. I know we're doing the joint strategic needs assessments for the ICP strategy and all of those things. There's quite a lot of talking going on between people about different things. And certainly at ICB local authority level, I think we probably need just to make sure we're aligned.
Yeah, that sounds like an excellent idea, Richard, to me. Thank you. Carol is actually chairing the next meeting, and we'll form the agenda with a little bit of consultation. So,
yeah, if you say yes, I'll get them preparing papers and things, if that's okay.
Okay, thank you, Richard.
Thank you.
Well, if there's nothing else, then I'd just like to thank you all for coming, and we'll see you in 2 months' time. Thank you.